Welcome to this TCT Connect eSymposium, sponsored by Philips. My name's Andrew Sharp. I'm a consultant cardiologist from the University Hospital of Wales in Cardiff in the UK. I'm joined by a world-class faculty today to talk about DEFINE PCI, the one-year results of which are being released at TCT Connect in 2020. We're also going to talk about IFR pullback and IFR co-registration and how they can help us in PCI procedures. I'm now going to introduce the faculty. First, we'll start with Manish Patel. Manish, hi, how are you doing?
Great, thanks. Thanks for having me.
We also have Ziad Ali from Columbia in New York.
Hi, Andrew, how are you?
We have Alan Jeremias from across the water in Long Island, New York.
Hey, Andrew and crew, how are you?
And we have Konstantin. Introduce yourself, Konstantin.
Yes, hello. My name is Konstantin von Somühlen from the University Heart Center Freiburg-Bad Kötzing in Germany.
Well, we're going to start with Alan Jeremias. So, Alan, we're going to be talking a bit about DEFINE PCI today. Tell us about the study. Why was it performed? Tell us a little bit about the early results that we've already published.
Thanks, Andrew. Maybe I can recap quickly the original findings of DEFINE PCI. As you all know, the purpose of the study was to see in what percentage of patients do we still leave significant ischemia behind. And we have some information from multiple studies with FFR that were done post-PCI, which demonstrated that about 10 to 20% of patients still have an FFR below the ischemic threshold of 0.80 after what appears to be a successful angiographic PCI. The issue with those studies were that they're all retrospective and the data set that we had, I think, wasn't of the highest quality in terms of the scientific aspect of it. So DEFINE PCI was a single-arm observational study of 500 patients where we checked IFR before to make sure that we had, in fact, patients who had significant ischemia, but then everything was guided by the angiogram. And when the operators felt they had a good angiographic result, and normally they would have concluded the procedure, what we asked them to do is to do a blinded post-PCI IFR and an IFR pullback, with the question, what percentage of patients still have significant ischemia? And importantly, when we do the IFR pullback, and we're going to talk a lot more about that shortly, we can also localize where the ischemia is coming from, which potential lesions are causing residual ischemia. All of that obviously was done in a blinded fashion. After that, the study was concluded. And the reason we did it this way is to basically assess, as I said, what is the state of the art after we feel we did a good job with an angioplasty, but importantly also to follow those patients. And Manish is going to talk more about the one-year outcomes, but basically follow these patients and see what the natural history is. This is how the study played out. This is the individual IFR gain post-PCI. And as you see on the left, there were some patients starting off with an IFR of around 0.2, obviously a huge amount of ischemic burden in those patients. And after that, they basically normalized after PCI. So you can imagine that those patients derived a significant benefit from PCI. But then there were plenty of patients that had kind of borderline IFRs with very, very marginal improvement. And our hypothesis was that those patients might not derive the same amount of benefit. So I'm going to show you a case example in the study. As you see, there was a pretty high-grade significant distal LAD stenosis. On the right, this is how the final angiogram looked. Reasonable angiographic result, and the procedure was concluded. We did a blinded IFR, as I mentioned before, afterwards. And this is the physiology. So before, IFR was 0.39, again indicating that there was a critical amount of ischemia. After stenting the distal LAD, it improved to 0.74. And when we did the pullback, you see that actually that did a good result in the stent. There is no step up at all. So that's not the problem. But what the problem is that there was a, I would say, very, very mild angiographic stenosis in the midsection of the LAD, which had a huge physiologic gradient of 25 points or so, leading to a still significantly impaired IFR. And the idea would be, if the investigators, or I guess in clinical practice, if we would do this pullback on a routine basis, and we would recognize that, of course, to put a short stent in that mid-LAD and fix this problem would be very, very easy. So these are the results in aggregate, a total of the 500 patients, 467 of which qualified for analysis. And we found that 24% of these patients still had significant ischemia post-PCI with an IFR of 0.89 or less. The good news is when we did the pullback, we found that the majority, more than 80% of these had focal lesions, which potentially could be fixed. And this is the breakdown, if you will. 38% had focal lesions within the stent, 31% proximal, and 30% distal. So about a third. It's really kind of hard to predict. But when we do this pullback in a systematic fashion, what we find is that we leave behind lesions distal to the stent, proximal to the stent, and also the stent is not optimized in most cases. And then this is kind of the provocative part, which obviously we don't know and we need to do more studies. But theoretically, if all of these focal lesions could be addressed with additional PCI, we could reduce the residual ischemia rate from 25 to 5%. Andrew, back to you.
Thanks, Alan. And I think a lot of people, when they hear these results, they say, well, you just didn't look at the angiogram properly. But we did a core lab analysis, didn't we, looking at the luminography and doing QCA of the lumen just to see whether the operator's eyes weren't working or whether these were truly silent lesions. And do you have any comment on that?
Yeah, so there was no correlation between the angiogram, even by QCA, and the post-PCI physiology. So it's exactly what you said, that basically you can't predict based on the angiogram where you're going to have a focal step up from the physiological profile.
Well, I'm going to bring Ziad Ali in now. Ziad, we're going to talk a little bit with you about what we've known before this study about post-PCI physiology, what the significance is.
Thanks, Andrew. Well, of course, post-PCI physiology is nothing but old. In fact, the original work by Grunzig, who was truly a physiologist, he used to measure the physiological gradient both pre and post any intervention. And so there's a very long precedent for assessing post-PCI physiology. I think it's clear that the role of post-PCI physiology is very important. So, I guess one of the questions is, how did we evolve over time from, using originally tubes and then wires? And then I think a big move in our field was when we started to see some of the data that came out from post-PCI FFR, which clearly showed that the more ischemia you resolve, the better you do, and that we could even dichotomize to some degree a post-PCI FFR that had an improved outcomes. And so why do we switch to a non-hyperemic pressure ratio? Why IFR? Well, really, it's the same reasons that we use IFR for any other reason. I mean, because it's less patient discomfort. Certainly, you don't want to give the patient a second or third round of adenosine, which can make them uncomfortable. It's faster, which is also very important. And finally, it's cheaper. So I think the value of post-PCI IFR is it really tells you whether you did a good job.
Ziad, I think in addition to what you just said, it's also important to recognize that I think IFR pullback is superior to an FFR pullback, because doing a resting pullback will minimize the crosstalk between multiple lesions, which of course happens when you induce hyperemia. So the IFR is not just easier to do, faster, cheaper, but also I think potentially more accurate.
I think that's a great point. And of course, maybe when we started to use physiology, we were doing, perhaps a little bit simpler lesions where there's just one gradient to pull across. But in the current era of PCI, there's a lot more diffuse disease. There's a lot more burden of disease, and the pullback, sort of the how to treat rather than just whether to treat, is a major advance in the field.
Great. We're now going to bring in Manish to talk about the one-year results of the DEFINE PCI study. So Manish, tell us about what these new data show.
Yeah, maybe I'll show you the data and then put it in context of the wonderful sort of conversation of Ziad and Alan just said of why do we think about not just how, should we treat, but how do we treat, and what do the one-year DEFINE PCI results show us? We had the pleasure of describing, as you can see here, the one-year results, and I described these on behalf of all the investigators and most importantly, the patients And so I do want to acknowledge that. These are my disclosures, and certainly there was research funding from Philips. Alan's already talked to us about the overall trial design to define PCI and what I'll call the acute results. So the results of what did we learn when we let investigators do the PCI to the best of their knowledge and then do a blinded pullback? What percentage, as you saw, of patients still have residual ischemia or physiologic reduction? So, one would ask, what were the goals of the 1-year results? And the 1-year results, as you can imagine, were to follow those 500 patients. And you can see here that we had 500 patients enrolled, and we did a post-IFR data in 535 vessels and 480 patients. And that's because there was some dropout, as you know, from the original study. And so we had an analysis data set of 467 patients in 520 vessels. So still fairly robust set of group of patients. And as I said, the 1-year outcomes that we were looking to identify were first, maybe importantly to recognize, in 500 patients, demonstrating clinical outcomes is often difficult, certainly even at 1 year. And so we know that angioplasty can reduce symptoms. So we were looking both for the clinical outcomes, but also the symptom improvement. And then we also recognize that these are hypothesis generating. It's a 500 patient important study that tells us about physiology, but we recognize as we get these data that they will help us better understand and think about treatment algorithms that, of course, would need to be tested. I'll just cut to the chase and sort of say, how did we get and what did we see? We analyzed the entire data set, and we looked in the people at 1 year and said, are there post hoc cut points that can help us best identify where people have differential effect in their clinical outcomes and symptom outcomes? And we're going to go deeply into this cut point of 0.95 or greater in a second, but you can see here, at least in defined PCI, when we looked at patients who achieved a post-PCI IFR of 0.95 or greater, this KM curve shows you clinically driven target vessel revascularization, myocardial infarction, and certainly you can see that there's a statistical difference, and the range of outcomes is between 1.8% versus 5.7%. And we recognize that this is important. We also went further and said, what about cardiac death, spontaneous MI, something that is not even a decision point for any of us. It's just, did the person have a spontaneous myocardial infarction? Did they have cardiac death? Here you can see a very low number in those that had an IFR greater than 0.95 or equal to it, and 3.2%. Again, small numbers, but encouraging, and certainly with the hazard ratio that's elevated and some statistical significance, it starts to make us think that this might be meaningful. I'll show you one final piece of data. This is a complicated slide. By now, many of us, having looked at the ischemia trial and other results, have started to look at these curves to see how do people's symptoms get better over time. And I'll just orient you to this slide. The first is that the total group is in the first column, and then the second column are people that have daily angina, and then sort of weekly to monthly. And then the far right is people who had no angina or no symptoms. And then as the curves go from right to left, people get better, or their anginal score gets better. And you can see that at 1 year, those people who are having daily angina with this cut point seem to get better with their symptoms. And certainly those that had monthly angina got better, and helps us understand how people are doing. So at least I'd conclude this portion of saying, in defined PCI at 1 year, despite angiographically successful PCI, in highly symptomatic patients at baseline without residual ischemia and post-PCI IFR had a greater improvement in their anginal symptoms. And that cut point of 0.95 we're going to talk about in a second, compared to patients who had residual ischemia. So we saw that if you could achieve a cut point or an IFR of 0.95 or greater, it was associated with event-free survival and improvement in symptoms. And we're going to be studying this prospectively. So I think these are certainly important findings and help us understand where we might need to go in the future. But maybe to Ziad's sort of example, I might take it beyond turning on the light switch. I might say that we often, if we weren't thinking about an intervention, we would say, should I use a drug? Yes. Then after I think about using that drug, I often have to know, what dose should I use? And so we do studies to identify which dose we should use. So another way of thinking about our problem here is, should we do revascularization? Yes. And then we did the best we could. Then the question is, what dose do I do, or how do I do it so I get to an effect that improves that patient outcome?
That's great, Manesh. I mean, we have seen a signal across many PCI studies going back decades that there are a proportion of patients who do not respond symptomatically to PCI. Suddenly the curtains are opening, and we could probably do the metaphors to death here, but we're starting to see that this 20-25% of patients who didn't get better after a PCI in all of these studies, we're starting to see a signal of one of the possible reasons for that. And it becomes increasingly intuitive that if we are leaving behind the problem that we set out to fix, we may end up with a less effective result, particularly in those who have the most to gain with high symptom burden.
Yeah, I guess I would say that there's no perfect answer for any patient. We're always trying to individualize care, but as I sort of used with the other analogy, I think what we know is as we heard already, that Grunzig originally thought physiologically getting people as close back to normal as possible would be the goal. And even in that New England Journal original publication, we saw gradient improvement, we saw anginal symptom improvement. So we've known this story for a while. It's just maybe we haven't had the mature technology to deliver it. So as I think we've already described, we now have technology and tools such as pullback. We're going to talk about co-registration in a second, where not only can we say, okay, there's a risk benefit to revascularizing this patient with angioplasty. Should we be doing it? How and where should I do it? And then does that lead to better outcomes for my patient, both symptomatically and clinically? And I think I have and others have said early on, before we had all of this technology and ability, it seems like a higher bar for an asymptomatic patient to make them feel better, obviously. And so therefore, the lowest bang you're going to get are the asymptomatic patients. But as you get more symptomatic, you have lower physiologic baseline scores, or you have more residual ischemia, you have opportunity to improve our patients. And so I think, as you're saying here, hopefully the defined PCI one-year outcomes are starting to show us how do we build those targets to improve our patient outcomes.
I'm going to bring in Konstantin here for his thoughts. Konstantin, what do you make of these results? Are these going to influence how you practice PCI?
These results from defined PCI show us that guiding PCI by eyeballing, simply relying on the angiographic result, belongs to history. We know from studies like Courage that post-PCI angina is common and is a relevant problem for the patient's quality of life. And maybe we now have a solution for this problem, the remaining stenosis in up to 24% of all these patients as found in the study. And indeed, this is a very relevant number of patients and shows us that we still have a huge potential to improve interventional technology and quality, with the aim to improve the outcomes, as we have just seen. And we have to think about maybe a new cutoff. Is it 0.0? Is it 0.95? Is it the higher, the better? So maybe we can discuss that later on. But to continue, on the one hand, that means that we have to use physiology before doing a PCI in order to detect all stenosis that are relevant to the patients, as we have seen in the previous example. And as we have already discussed, IFR is a perfect tool for that, since it can not only detect single lesions, but it can also evaluate serial lesion and even discover lesions that are not detectable by the pure angiographic view. And later on, I also have an example on that. On the other hand, these data should also encourage us, of course, as Ziad mentioned, to perform post-PCI IFR on a routine base to see if the light switch works, in order to recognize how to treat the individual patient and its stenosis, and not only who to treat. I think, however, that it will take some time to introduce post-PCI IFR into the clinical routine, since every interventionalist thinks that he has done a great job after putting a stent in. Yes. So I think a change of mind really has to take place, and these data absolutely encourage that.
Sometimes there's something we can do to fix it and to further improve physiology, and sometimes there isn't. But at the very least, you understand that you leave some ischemia behind, and you might treat that patient different medically afterwards. At least you have the knowledge, and you don't think you did a perfect job when in fact you didn't.
Yeah, I think that's really important, Alan. Knowledge is power. If we're ending up with a pattern of diffuse disease left behind after you've dealt with a critical lesion, you're going to continue your vasodilators, set the patient expectations. If we're getting a final result from a focal lesion of an IFR of 1.0, I think we can have increasing confidence that we can withdraw those anti-anginals if there's no other substrate and manage the patient differently. So these have real implications for the real world day-to-day management of stable angina patients. They don't like their drugs. They want to be off their drugs. That's one of the reasons they're having PCI. And why wouldn't you want to know if you've abolished the problem that you've set out to treat?
What we're really dealing with might be something we see in all of medicine, which is inertia. We're used to doing things the way we were treated. and the way we've been trained to do it and the way we treat it every day. So the change practice, what I often say is we need the rational brain to show us the data, and then we need emotional or case examples that show us where we've done something wrong. And so I know we're going to get to case examples, but I would say that, you know, it's almost like we are, and I've used this analogy since we've used different analogies. If you're in the cockpit and you have a light that's really important to taking care of this flight, this patient's care journey, and you don't look at it, then certainly I think that's an opportunity missed. And so what I worry about with what we've just described is we're starting to now have a very important set of data that show us that continuing post-PCI physiology is going to be important. We're going to have to change the culture, even though let's say that there's some of those data being existing, that's going to be important. And we need to ensure that we do that with science, but certainly we also do that with rigorous sort of continued push to say that your angioplasty may not be complete until you've done intravascular imaging and intravascular physiology to confirm both the stent and potentially the physiology in that vessel.
Alan, is that your routine? Have you built these findings already into your clinical practice?
Well, partially, I'll be honest. You know, I think every time I do measure physiology before and the wire is available, obviously, you know, it makes sense to use it after. More and more, to be honest with you now, actually with the release of the new wire, which is fantastic in terms of the handling, and we can discuss that later as well. I basically use that as my, you know, routine angioplasty wire. There's no need to change anymore. And then obviously the wire already is in place, so it's easy to check afterwards. You know, in cases where I don't measure physiology, I still don't open necessarily, you know, a wire afterwards to check, although, you know, you can make the argument that you should. But certainly in all the cases where you check before and you guide your procedure based on the physiology, based on the IFR pullback, it makes no sense not to check it.
Yes, this new wire that we Europeans can't get yet. So Ziad, tell us a little bit about this new wire and how its handling and performance might just encourage us to go back and check the IFR at the end of the procedure.
So that's actually an interesting story, Andrew. So Alan and I decided to live record the first use of the OmniWire so that it was completely genuine. And it is really, really good.
I can
So we
attest,
did-
even Ziad could actually wire the lesion. I was
Oh,
surprised.
really? Yeah, excellent.
No, no, I mean, we did a multi-vessel case. We used the same wire in multiple vessels. We went into side branches and the drift was very little and we could perform the PCI over the wire. The connection is much better. I mean, it's pretty rare when I come away saying, this is really, really good and a major iteration. And to be honest, one of the things we can discuss together is why didn't we all do post-PCI physiology before? And the truth is that it was a real pain, right? The wire turns into a piece of shrapnel. You don't want to go put it down the artery. It's getting stuck behind the stent. Now you've broken it. Now you need to get another one. It's another cost. Somebody has to go and run and get it for you. The angio looks fine. Let's just get to the next case. And then now we're getting to the point. I mean, that's why I think this is such a major iteration, that the wire handles so well. You can actually do the PCI on that wire. The connection and disconnection is really seamless. And then you can just, you know, reconnect, get a result to see whether you did a good job, do a pullback, and you're done. So all the things that I talked about before in terms of making the procedure faster, making it safer, make it more efficacious, it really matters. I mean, the one thing that you guys have probably heard me say before is that physiology was a science that was ahead of the technology. And I think we're finally catching up on the technology side so that it becomes more utilitarian in the cath lab.
Well, that's high praise. Manish, have you had a chance to knock this wire around yet? Are you using it as a workhorse?
Yeah, we were just getting our hands on it, and I agree. I think that the wire is starting to, as Ziad said, and not just the wire is fantastic, but I think the entire field is now going from where we might say, for all the reasons described, you know, second administration of adenosine, how easy and how hard is it to hook up? What does it look like after you've done the first intervention? now co-registration that we're going to talk about in a second. How does it look for even where the world's going for both IVUS physiology, wire and non-wire based technology? So I think the impetus, actually, I would say by many on this screen and others, to say that we shouldn't accept, poor technology. Physiology should drive our revascularization. We have to push, and thankfully companies have followed, but we have to push our colleagues and others to demand better techniques and technology to get the things done that we want. So I do think it's a step forward. I do think that these data and these types of sort of iterations have made the entire field go forward. If you just take a step back and get to non-adenosine based physiologic measurement like IFR and see what that's done to the field, it's dramatically changed what's going on with coronary physiology, where one could argue before that there were 8% of angioplasties at most, maybe 10 in the United States that were getting some sort of physiologic assessment in the cath lab. That's changed, and that's changed for all the right reasons, I think, but I think it should continue to be database driven and certainly demanded by our colleagues and others who are saying, listen, you can't expect us to do a volume that we want to with the care that we want to without technology that's going to be very easy to.
Manish, can I just clarify for anybody watching? We've talked about two different numbers here. We've talked about less than 0.9, which is the ischemia threshold that we've used in DEFINE FLAIR IFR Sweetheart. And then we've also talked about a different number from DEFINE PCI, which is 0.95. So can you just, as simply as possible for people who maybe aren't high users of physiology, explain what the two different numbers are signaling and how we use them?
Yeah, and I want to be very clear that the 0.89 number is the most evidence-based number. The 0.95 number that we're talking about right now is a hypothesis generating number as we start to test this. And we also know that this physiology is a continuum, right? So we recognize those data, but the 0.89 number is the number that we're using to say, should I revascularize this vessel? Is there a significant reduction in physiology that likely will lead to improvement? And that number has been now, as you've heard, tested potentially more than almost any other number outside of the FFR number of 0.80, which was studied head-to-head in IFR 2 trials now, DEFINE and Sweetheart. So I think people should feel very confident about the 0.89 number to say, should I do something? And back to my analogy, how far do I go and how far do I need to go to do something, or what's the dose, or how do I do it? That's the 0.95 number is saying, what's the target? Now that target of 0.95 is what we've seen in DEFINE PCI at 1 year. We need to study it prospectively in a randomized fashion to say, if you get to that target versus doing what you usually do people get better outcomes?
Yeah, Alan, what do you think? How do you interpret this 0.95 number?
Yeah, it's a good question. I guess it depends. Like in all things in life, right? It's always the gray zone. But just to Manish's point, I think the bottom line is this: when you go in, you want to see, is there ischemia or not? I do a PCI? Once you made a decision to do a PCI, you want to get to as high of a number as you possibly can get, right? Ideally, if I was able to, I'd like to get everybody back to 1.0, right? 1.0, then there is no ischemia at all. That would be the ideal. Based on the post hoc analysis from the DEFINE PCI, we identified this number of 0.95 or greater as kind of the optimal result. Knowing that in many cases you probably won't be able to get there, but at least you have something to aim for. Now the question is, okay, if we can't get to 0.95 in everybody, what should we doing and how should we guide it by? And I think that's where it's really, really critical to do the IFR pullback post PCI, because that will tell us, is there an opportunity to do additional PCI, maybe optimize the stent, or maybe find another focal lesion, like I showed you in the case, that we can maybe do another stent and eliminate the gradient? Or is it all diffuse disease, in which case we understand, okay, there's no additional PCI that will help the patient, but at least we know what we're dealing with when they come back, 2-3 weeks later to the office. They still have chest pain. I don't have to run and order another stress test, burden the healthcare system with additional testing, because I expect them to have some degree of angina. And then we also understand how much potential benefit in a PCI we can get. In some cases, I didn't show you those examples, but in some cases, the IFR before and after is the same. Obviously, in that patient, I wouldn't expect any change in their symptoms, right? in some cases, the IFR is 0.3 and it goes to 0.6 or 0.7. You know, in that case, I would say, well, yes, there is still ischemia, but maybe less so, and maybe we had some benefit. So it's really important to understand these nuances and put this together to kind of make the best decisions in follow-up when we see these patients back.
And the beauty of the pullback technology and its new iteration, the co-registration application of it, is that we can get this information before we put the stent in. So we're going to come to Konstantin now, who's got a couple of cases that really illustrates this, that, you know, yes, we really need to know what that final result is, but we can actually predict this in advance now of putting a stent in using the co-registration technology. Konstantin, have you got a couple of cases you could show us that just really illustrate how we can be forewarned of some of these scenarios of residual ischemia or angiographically misleading lesions?
Yes, sure. That's a very good point. And as I already mentioned, it's important also to do physiology before putting a stent in, of course. Okay, so I brought you two short cases, and I just want to show you what we experienced there in the cath lab. So these are my disclosures. And the case number one is on a 62-year-old male patient with a history of multiple PCIs, and he also has an ICD implanted due to sudden cardiac arrest that he had. And in 2017, he suffered from an end-STEMI SAS with an RCA stenosis, which was stented with a good result. And now he has rapid progressive angina in a CCS3 stage. And in the echo, he has a new hypokinesia in the posterior wall. So this patient directly went on the cath table. And here you can see the image. And to be honest, I was first distracted by this stenosis in the segment 1-2 on the left-hand side. And since we did not have an evidence of ischemia so far, I, of course, decided to do an IFR. And here is the co-registration. And the result was very surprising. So we did the pullback, and finally the stenosis that was suspicious to me in the beginning, so in the beginning of segment 2, wasn't relevant at all. So if you look at the yellow dots here, it's just 0.05 points that we would increase the measurement here by putting a stent in. But the real problem is in the proximal LAD, and I hadn't seen that on the first view. And of course, I did some more projections with high definition images, and now you can appreciate here that there is an instant restenosis, which is indeed severe. And of course, we treated this vessel and this lesion with a drug-eluting balloon, did a final IFR in this patient, and it was 0.96 in the end. So this is a perfect example that you sometimes miss lesions when you're distracted maybe by other lesions. And case number 2 is on an older patient. He's 82 years old, also a male patient with multiple PCIs in all coronary vessels. And he has a high bleeding risk. So he has severe recurrent GI bleedings and also epistaxis. And now also has progressive angina with a CCS3 stage. And we performed a stress echo, and he had a hypokinesia in the anterior wall at 100 watts. And these are the images. So in the left coronary, the right coronary artery was fine. And here you can appreciate that there is something going on in the left main. And on the left scene, you can also see that there might be some lesion in the LAD just behind the diagonal branch. On the right-hand side, you have a different projection in this patient. It was actually difficult to project the LAD, but anyway, we did a sync vision co-registration in this patient, and this is the result. So we have more or less diffuse disease. This distal LAD lesion that you have seen on the previous scene isn't relevant at all for the patient. And what we see if we have a closer look and start doing a virtual PCI is that we have a left main stenosis there, but it doesn't contribute at all to the hemodynamic significance in this patient. And by the way, we also did a measurement into the LCX and obtained the same result. But you can see that the proximal LAD is a significant lesion. And remember, this patient has a high bleeding risk. So you don't want to implant him a full metal jacket with 5 centimeters of stent. You maybe really want to selectively treat the area causing an ischemia, just in case that you need to stop dual antiplatelet therapy earlier due to new bleedings. And we did that. and implanted a stent 24 millimeters long. And this is the beauty of the virtual PCI, that you can estimate in advance the improvement of coronary physiology, and that you also can define how long the stent should be. In this case, we chose a 24 millimeter long stent.
So in this case, you've put a pressure wire distally, you've demonstrated that there's a substantial drop in pressure across the vessel, but we've then done a pullback, and that's mapped the areas of pressure loss onto the angiogram, thus allowing us to draw where we would put our stents on the image, and it will tell us what to expect from the IFR after the case. How accurate is this in your experience? Is it giving us a sort of broad estimate, or is it really quite accurate?
It's very accurate. I couldn't believe it, but there's, let's say, in this one patient, there was an estimate of 0.95, and we obtained 0.96, and it's really amazing how these results can estimate what you reach after PCI. So it's very accurate indeed.
So this is giving us this power, really, of saying, I haven't put a stent in you yet. I know that leaving residual ischemia might be a bad thing. If I put the stent in there, in your case, near the RV branch in the first case, I'm actually not going to do much. I'm going to lift by 5 points, and I'm still going to be below an IFR of 0.9.
Absolutely.
And it really does allow you to map out the length of the stent to within a couple of millimeters, and give you that knowledge before you commit, which I think is a really key part of this technology. You don't have to go ahead and put a stent in if you find that it's a diffuse pattern that's unlikely to relieve ischemia.
Absolutely. So it's a great tool, and it works very well, and it gives us important information before doing the PCI in diffuse disease, especially in serial lesions, and it gives us surprising results sometimes, as you've seen in the first example. And an important point is that also this technology really is very convincing. As you're challenging yourself, everyone is missing lesions. It happens in clinical routine. But this tool really helps us to get a very good result and to do a very, very accurate planning in advance.
And Ziad, you're an expert in coronary imaging. This isn't a surprise to you, is it, that we're going to find these angiographically silent lesions? Angiography is just not that good a way to assess coronary disease.
You know, it really begets you to use the planning tool. Why wouldn't you want to do that? And what we know from multiple studies is that if you put in very long segments of stent, it increases your stent thrombosis rate and your target vessel failure rate. So if we can sort of minimize the amount of stent that we need to maximize the amount of gain, it should only improve long-term physiological outcomes.
And it's an individualized therapy for the patient, of course, as you've seen in the example. You have a high bleeding risk patients, you don't want to put too much stent in. It's a perfect tool. You can plan how much stent you want to put in and what IFR you want to reach at the end.
And I would track on what Konstantin said, is that, you know, you can end up doing a beautiful and perfect imaging guided PCI, but still have ischemia. So it's really not that one modality or the other answers all the questions. It's just like, you know, you need a toolbox, and it's really to answer the question with the best available tools that we're all trying to achieve. And, you know, I think there became this sort of false sense that, well, I've already used a pressure wire, I can't use an imaging catheter now, right? I mean, I don't know where that came from. I understand that cost implications are important, but the most important thing is that you do the right job for the person on the table, right? It's not like they came in with a budget at the beginning. The patient didn't do that. It's our responsibility to use all of the technologies to really optimize the PCI.
Yeah, I was just going to add to that. I mean, I think we're so acutely aware of the costs inside the procedural room, which I think is important. But, you know, we're engaged in a PCI bundle here in North Carolina, where we say this is what we'll deliver the care out to 90 days and soon 6 months for. And I can tell you, having that patient come back, or not knowing that the patient has angina, or not being able to manage what that patient's expectations are much more costly than IVUS catheter, or a stent failure, or a stent in the mid LED when there's really ischemia in the proximal LED, or actual total mischaracterization of how you should treat the patient, as I think Alan said, maybe a LEMA is what this patient needs rather than a PCI focally with continued pain and PCI again. And
I give an example that Konstantin just showed. You have a patient, you end up stenting the wrong lesion, they come back, you don't know why. So you don't do another angiogram because you just look at your last angiogram, you're like, it's perfect. This guy's crazy. And so you send them back home, and then they come back again to the hospital. And then they come until the point at which they end up going to another hospital. And so I think doing this, I know Alan likes to say this all the time, sort of doing this right the first time really saves you in the long run. With data that's showing that we have like a 20% MI rate in the first year after your first ACS and a 20% residual chest pain, these are not small numbers. And even impacting them on a small scale can have a profound implication on the costs.
So yeah, just to correct you, the line is sometimes you have to do the right thing by the patient.
Yes. Alan, I think you've got another example to show us, haven't you? You're using this technology to plan PCIs.
Yeah, thanks, Andrew. So Konstantin showed us some nice core edge cases. This is another way of using it. This is a case actually Ziad and I did together at St. Francis. This is an ultra-low contrast angiogram in somebody with advanced renal dysfunction. What we do is we always separate the diagnostic angiogram from the actual PCI. So the patient had an angiogram with 9 cc's of contrast. And what we found, as you see, is a pretty high-grade stenosis of OM1. What we typically do in this case, we stop the case, we bring the patient back a couple weeks later, and then the goal of the procedure was to do this with zero contrast. Just to show you how we engage the guiding catheters by injecting saline, and we're looking for EKG changes to know that we actually engage. And then what we do is we kind of recreate a metallic silhouette of the vessel by basically wiring all the branches. And then what we do is finally wire the lead, the pressure wire. And as you see here, we do a pullback, and we actually do an IFR core edge just based on the metallic silhouette of the wires without injecting contrast. So that's possible also. And in this case, as pretty clearly indicated, there is a very, very high grade stenosis with a huge gradient at the lesion, and the IFR is 0.54, obviously pretty critical ischemia. The next step, of course, is then to guide this procedure imaging, since we can't inject contrast. What we did in this case was a tri-registration by adding on intravascular ultrasound. And what we do here is we find the landing zones distally and proximally. And based on the tool that Konstantin already showed you guys, we kind of figure out how long of a stent we need. Based on the IVUS pullback and co-registration, and then basically just execute placing the stent. We kind of have this template from the previous procedure, so we can have a rough idea of where we're located, and then based on the IVUS imaging and the IFR pullback, we place the stent, and then follow up, of course, with IVUS and physiology. And this is the final result. IFR basically normalized back to 1 in this case. And of course, we also make sure with the intravascular ultrasound that there is no edge dissection, that the stent is fully expanded. And if all of this works and the patient is asymptomatic and there is no EKG changes, we basically conclude the procedure without shooting any angiograms. So in this case, we did this with zero contrast.
It's a really impressive use of the technology, and also speaks, Ziad, to your comment about how these old distinctions of who to treat, how to treat, and you use IVUS for one, physiology for another. It's all going now. It's all these co-registration technologies are changing the way that we can handle these very, very difficult patients.
I think that's exactly true. I mean, I remember doing my first zero contrast PCI in 2015. The patient had an elevated creatinine, and I had measured the FFR and CFR before the case, proved there was ischemia. Then I did a pullback, mapped what part of the artery it was in, then sort of marked the distal reference with an IVUS catheter, marked the proximal catheter with an IVUS catheter, put the stent in, post-dilated it, and then the nurse asked me, goes, aren't you going to take a picture? And I just thought, why? I measured the pre-PCI physiology. It was ischemic. I put in a stent, the edges are perfect, it's fully expanded. I measured the post-PCI physiology and it's perfect. I'm done. And really that was sort of the evolution of this. And now when you have the technology where you can do things like tri-registration to see not only where you can see the artery from the inside out and the outside in, but also have that coupled with physiology. I mean, it really is, in many senses, eliminating the need for fluoroscopy or an angiography other than to be a guide for where you're going to need to go.
Yeah, Manish, I heard Ziad once refer to contrast as poison. And that any tools we can use that can reduce contrast administration, like the co-registration tools we've just seen, that's not a trivial impact. If we can keep someone's GFR at 20 instead of 10 following a PCI, that's a really major difference to that patient's life.
Yeah, no, absolutely. I mean, I think, you know, what you've just seen is again, I think when we think about the world of interventional cardiology, there are always people who are pulling and pushing us to places we need to go. So zero contrast PCI is fantastic. And what you've seen is a great example of how these tools help us get there. And you know, where the world is very far away from even zero contrast PCI, but there's a lot to get to by just saying, hey, can you do PCI with one shot or fewer shots? Yeah. And then zero contrast, right? So what I would argue is, much like the nurse's reaction to Ziad, the audience in general is going to have a belief system so tied to angiograms, right? And so to move them from angiograms to no angiograms, the first step might be just to say fewer, safer angiograms and reducing that risk.
I would even argue that, you know, based on the data we just discussed from DEFINE PCI, the angiogram really is overrated. We rely on it 100%, you know, but I feel like we rely on it way, way too much. And so we actually use the procedure and inject contrast really for no good reason when we have much, much better tools to assess which lesions need to be treated and also to assess the final outcome. So I think, in all honesty, it's not necessary in most cases to do as many pictures as we do.
So, Alan, 500 patients, DEFINE PCI. We've got some strong signals here of clinical benefit, but we need more. What's the next steps for this area of research? Tell us about the trials that are coming.
So the follow-up study of DEFINE PCI is going to be DEFINE GPS, and it kind of builds on the data we just discussed. As we all talked about, obviously, it's important to do physiology post-PCI, but maybe even more important to do it before. And just like Konstantin showed us, you know, in the cases that were guided by physiology, that's kind of the concept of DEFINE GPS, where we want to be doing a pullback, an IFR pullback with co-registration ahead of time and really fully plan out the procedure. We've mapped the entire vessel from a physiological standpoint. We have certain goals we want to achieve, you know, an optimal result being 0.95, but an acceptable is 0.90 because we recognize we don't get there in every patient. And based on those goals, what we're trying to do is to really plan the procedure ahead of time and then execute in the GPS arm, if you will. And we're going to compare that strategy to a standard angiographic approach, plus minus imaging, intravascular imaging is optional in both groups to see if we can, in fact, show that we're going to have a reduction in hard endpoints. And the study is going to be somewhere between 2,500 to 3,000 patients. So it's going to be adequately powered to show us hard endpoints. And I think, and I hope, frankly, it's going to be the definitive study to show that physiology guidance is helpful in reducing major cardiac events and then become the standard of care.
So we've seen that if you treat a vessel with a low IFR or FFR, and you're guided by that finding, that you have a better outcome than if you're guided by the angiogram. So the difference with this study is that we're going to not just get the vessel level value, you know, the 0.82 down the bottom end of the LAD. We're going to do a pullback, co-register it as we saw with yours and Konstantin's cases. And then we're going to use that data to plan and execute the PCI and to try and ensure with post-PCI physiology that we've achieved the goal of abolition of ischemia and hopefully this perhaps higher standard of result with an IFR of 0.95 or above. Is that right?
That's the idea, because in all honesty, I think we were somewhat convincing in this webcast to say, look, it makes intuitive sense and we have some degree of evidence to support this. But in all honesty, for the skeptics out there, we need to produce a randomized trial to demonstrate that there is in fact a reduction in hard endpoints when we use the strategy, because it is a bit more involved. It is a bit more complex to do a procedure this way. And we have to kind of justify both the complexity and maybe also the resource utilization. So if we can show that in fact it will reduce bad outcomes for the patients and we reduce repeat hospitalization, in the end, we're going to also save cost. And the secondary endpoint of the study is going to be an economic analysis, putting both in the pot, if you will, right? The resource utilization, but also obviously the follow-up to see if in fact patients get admitted less frequently, and we might actually save cost with the strategy.
Well, I think that set you up nicely, Manish, for your takeaways from this discussion and the results of DEFINE PCI at 1 year.
I guess I would say that the best findings that I would say that we now know, and I reiterate some of what Alan has already shown us, that I think DEFINE PCI in its most basic form taught us that even in the best of our practice, we have patients that have up to a quarter of patients have residual ischemia in the vessel. And then the question is, what does it mean? And at 1 year, what we've seen is that there's a signal that those that got a higher post-PCI IFR, and we did a post hoc analysis using the cut point of 0.95, those patients had better symptom reduction and less clinical events. So it fits with how we think about what we are aiming to do. And we're now hopefully going to have prospective randomized data to confirm that a strategy of doing that will lead to better patient outcomes. And that's powerful because, like any technology or clinical care, I use the example of dose finding. You have to get to the place where you're then going to use that one to go prove that when I do that to enough people, they do better. So that's where we are with the findings from 1 year of DEFINE PCI.
Great. And Ziad, it feels like every time I open a journal, there's something new in this area. There's new innovation. It's quite an exciting time, really, to be an interventional cardiologist. You're pretty good at horizon scanning. Where are we going to end up?
If we can really get this angio-based physiological assessment right, it's a game changer. I think the same things that made IFR advantageous to FFR will be iterated forward. It'll be safer. It'll be less uncomfortable or less discomfort. It'll be cheaper. And it just fits in the workflow with things that operators around the world are very used to. So I think to me, that's the next big sort of blue sky thing. I think there's some problems that need to be rectified in that field, as everybody on this call knows. But in the meantime, I have to say, I think this improvement in the physiological wires is a really big step forward. I mean, it's very rare for me to say that I was truly surprised at how different this made a single case. It was just super quick, fast, utilitarian. There wasn't a lot of messing around, as we know we've had to do for years with physiology wires. So that improvement in innovation, I think, is a true advantage. And lastly, let's not forget that we're going to have continuous iteration in the software. It's going to become even easier. I'd like for the computer to tell me what's diffuse, what's focal, where's the lesion, what size stent should I put back if I have residual disease. All of these things can be iterated with AI, with computational algorithms as the future comes to the present.
Yeah, Manish, you're involved in several guidelines. I presume this is going to feed through into future iterations of the guidelines.
Well, as you know, guidelines and appropriate use criteria are complicated documents. I like to call them living documents, and they sometimes don't change fast enough, as we know. So my response to this is, I think so. I mean, the ESC has done a wonderful job in the chronic CAD guidelines, as we just heard about, and I'm sure the U.S. AHA-ACC guidelines and the criteria are going to hopefully evolve quickly. I think the take home from this program, hopefully for our colleagues and our patients, are that there's continuous innovation, and health comes when that innovation gets applied to the right patient. So we're going to keep working on it for sure. And I'm excited to be working with a lot of the people on this screen, but also just thinking about the different sort of partnerships we have to help this happen for our colleagues and our patients.
Well, patience is a great way to end. So Manish, Konstantin, Alan, Ziad, thanks very much for joining me today. So I want to thank Philips for sponsoring this symposium. I want to thank TCT Connect for giving us the opportunity to embed it within their really groundbreaking new meeting. And thanks to all my co-commentators, and goodbye.